The Next Breast Thing podcast is primarily funded by the American Society of Breast Surgeons. The support of sponsorships helps us offset some production costs. ASBrS does not endorse or co-promote any company, product, or service mentioned.
This episode of The Next Breast Thing is made possible in part through the generous support of Solventum Prevena Therapy and Mammotome Breast Cancer Diagnostics and Surgical Solutions.
Solventum Prevena Therapy has demonstrated a significant reduction in surgical site complications, infections, and readmissions. Take a proactive risk management approach. With Prevena Therapy, learn more at Prevena.com. That's Prevena.com.
At Mammotome, we offer a comprehensive range of products that deliver better outcomes in breast care. From biopsy to surgery, our advanced technologies empower clinicians with precise, trusted solutions. Together, we will transform the future of breast care. Learn more at mammotome.com.
Hey listeners, want us to let you know when new episodes are available? Simply hit the subscribe or follow button on the Next Breast Thing podcast wherever you listen to podcasts.
Also, join the conversation on our Facebook group by searching the Next Breast Thing podcast group on Facebook. On this episode of The Next Breast Thing,
The boat is still underwater. I still don't know how I'm going to get that out. I've got beavers.
At the Lantern Festival, I got permanent jewelry.
He's like 83 years old, just finished chemo for lung cancer. It was his fourth show of...
I did have a patient with implants in her chest that we had to remove.
Oh, yeah. So this topic is benign breast fibroepithelial lesions. 2025 ASBrS breast imaging guidelines provided updated recommendations designed to reduce unnecessary surgery. So today we're discussing what these guidelines mean in real everyday practice.
and this is in JAMA. This is a huge accomplishment.
Now, I'm going to take a little bit different tact on it, but I want to hear what you guys are thinking.
If it's 2 centimeters, are you still leaning toward excision or you're good?
So what, it's 6 millimeters bigger in 6 months? Okay, then I'll
where did it
size
start? Wait.
Yes,
It
I
started
think
at 5 millimeters. But what is guiding them to want excision? It's fear of cancer frequently. When do you say, I am comfortable watching this?
This is Carla,
Ellie,
Michael.
Susie.
And Susan. Welcome to The Next Breast Thing, a podcast by the American Society of Breast Surgeons for the entire breast community.
We're a group of devoted surgeons from different parts of the country.
Inviting you to journey with us into the science of breast.
Through the heart and soul of our breast community.
From advances in procedures and patient care to personal transformation, we're here to support you.
So, if you're part of the breast community and can't seem to find the answers, this is the Next Breast Thing.
Our topic today is ASBrS Breast Imaging 2025 Guidelines, specifically for the management of benign breast fibroepithelial lesions. That is a mouthful. But before we get started and into that really important topic, let's begin with some personal and professional updates. Michael, what's new with you? Is the boat still at the bottom?
Okay, there is a catastrophe on the pond, but it's not the boat. The boat is still underwater. I still don't know how I'm going to get that out. I've got beavers. I noticed the little trees around the pond started disappearing, and now I have beavers. So I'm going to have to find some way of getting rid of these beavers, or I'll have no trees around my pond. I diagnosed beaver by the little cone-shaped, newly chewed-off wood stumps.
But you haven't seen them, or do they have a dam? Could it be a muskrat?
Listen, do muskrats shoot trees? I don't know. It's a pond, and the trees are disappearing, and they're falling, and they're chewed up. That, to me, is a beaver. That's my differential diagnosis. Yes, I'm going to have to deep dive into beaver elimination. That's going to take precedent over the boat. Carla,
Michael,
Tell
hold
us.
on. Do you ever feel like you're on a reality TV show? And
No, I
someone's
feel like I
ranking
should
you
not
all
own
the
this
time?
farm and pond. When I tell people I have this, they go, why? And I have no good answer, and except it just adds to the weekend updates that I have.
So you
which
have
is
to understand, I ask him why all
do
the
not.
time. Because these stories become more ridiculous. And I'm not sure I believe any of them.
Every one of these stories is true.
But the strangest thing is, on my Instagram feed today, there was a beaver dam and it was showing the inside of it. So were you somehow in my Instagram? Changing my algorithm?
Maybe. All I know is I've got a beaver problem that I'm going to have to eliminate.
Well, be careful who you say that to.
Carla.
I just celebrated a birthday. So thank you all for all of your well wishes on my birthday. So you would think from my last update that I was turning 70 with the bird watching, but it was 30, guys, 30. So I spent a great weekend just outside Dallas. Friends of ours have a lake house outside there. And so I was there with my parents and my brother and his kids and them. And it was just great family and friend time. And you know how you come back from a trip and you're tired, and then you come back from certain trips and your cup runneth over. And it was sort of one of those birthdays. And so I'm feeling extra thankful and happy. So it was a wonderful birthday. So Ellie, we've missed you the last couple podcasts.
I know. I'm happy to be here. Piggybacking off of the wonderful job that you guys did with the sexual health discussion that Michael so enjoyed. I actually have been working with my hospital to try and bring a sexual health program there. So I sent off the application today. They have a Shark Tank where they fund new projects from doctors. And so we'll see what happens. But I've been working on that. So that's been pretty cool to do that for the first time. But it was all because of Dr. Rojas being here and hearing her at the meeting. And it's a testament what this forum does and how well the meeting works to bring ideas to people and hopefully gets funded and we can help more patients. So
Michael, are you volunteering for 1 day a week? And
Now that I've heard, I'm going to put my application in. I feel very comfortable talking about that with all of your patients.
I think you've matured and grown through this podcast.
Now, Susie has got a program and she knew a lot about it. I was impressed.
Susie knows a lot about everything. I'm learning.
She really does. So what about you, Susie? What's new with you? What new extreme sport are you doing?
No extreme sports, but I have a confession to make. This is directed at Carla. At the Lantern Festival, I got permanent jewelry. And on the last podcast, you didn't get into it. But Carla's like, why do people do that? It's not even permanent jewelry. And I thought about it. It was sweet. My daughter got a bracelet. I got an anklet. And it's just a nice memory of being there together and knowing that it's harder to take off is nice.
You know, ankle monitors are not permanent. You know that, don't you? This doesn't count as an ankle monitor.
Don't get me started on permanent jewelry. Don't get me started.
I thought it was welded into her wrist. And I had this whole discussion. How are we going to remove this? And what do we do? And my PA looked at me and she's like, what are you talking about? I said, she has permanent jewelry. And she's like, you know, it's not permanent, right? Why is it called permanent jewelry then?
I did have a patient with implants in her chest that we had to remove.
Oh, yeah, I've seen that.
It was awful. And they were metal. And they were in like the field of the bovie. So we would have burnt her. But it was gross. But yeah, I cut off all those permanent jewelry things.
I just have like the little anklet bracelet.
Oh, yeah.
We're all excited for you, Susie.
Yeah.
I'm glad you did.
It's a nice memory.
Glad that when the court order lets you get out of that.
Thanks,
Is
Michael.
it sweet?
Is that what you're calling that ankle?
An ankle monitor. Yeah, she's calling it.
Yeah, so I'm sticking with it. It's permanent jewelry.
I think it's good.
Susan, are you going to tell us anything?
Oh, I have so much to say, but I was at a wedding this past weekend, and it was one of those weekend weddings. They are so young, and I mean, they're not that young, but young and excited and just starting out on their life. And it just was such joy. It was a large wedding, and everyone there was just filled with such joy for them. It was really special, and it just reminds you of that feeling of young and the world is just in front of you. And then I look at all of us and The word is mostly behind us.
A year and a half, and let's see how that's going.
I just celebrated the 30th, I've come.
Well, some of us are younger than others, but one of my friends that I was sitting next to at the wedding, and I said this, and she looked at me, and that's what she said. She said, yeah, it's cute that most of their lives are in front of us, and most of ours are behind us. Does that not frighten you? And I was like, well, I'm in the moment of joy. Let's stick with that. But it was just a wonderful event and just filled with love. It was great. So aren't you happy I gave you an update? Look at that.
Yeah.
Life's about making memories. And Friday night, I took my dad and his partner to Barry Manilow. My friend sort of gave me a little hard time about seeing Barry Manilow, and he put on a great show. And we've seen them before, and my mom loved Barry Manilow, so we've been to see him as a family years and years ago. So to go back again, and he's like 83 years old, just finished chemo for lung cancer, and it was his 4th show of the week. And he was
That's
awesome.
intense. That's
He was
that's
awesome.
hard work.
I don't think I could do it. Definitely not. But he was awesome, and it gave me hope that in our 80s we can still be out there living life. Let's move on to our topic. ASBrS Breast Imaging 2025 Guidelines. Now, we put out as a society several guidelines on benign disease, and the society really approached this in a great way and very methodical. So this topic is benign breast fibroepithelial lesions. We see this all the time. I am sure everyone here sees this weekly. But sometimes there are management challenges for both the patients and the radiologist, the pathologist, all of us. 2025 ASBrS breast imaging guidelines provided updated recommendations designed to reduce unnecessary surgery. If someone is on our operating room table, they need to be there. It's not because we think maybe they should be, but we really want to be following guidelines with this. We want to improve consistency in management and ensure that higher risk lesions are identified appropriately. So today we're discussing what these guidelines mean in real everyday practice, how they may change our approach to fibroepithelial lesions in general, and what messages we should be communicating to our patients. So, Susie, let me start with you. Woman comes in, and my disclosure is I was one of the authors of this manuscript and these guidelines. And I can tell you, it was not easy to come to agreement because the literature is not always clear. So let's start with this. What is a fibroepithelial lesion to you?
So what these tumors are, they have both an epithelial component and a stromal component. And I think they're really identified. Sometimes they're bilobe. They can mean different things on that from a imaging standpoint as well as from a pathologic standpoint on there. And they can grow. And sometimes they stop growing. Sometimes they're bothersome. Sometimes they're not bothersome at all. And what I really appreciated, and I wanted to actually say thank you, was many times I say, oh, the American Society of Breast Surgeons, we believe this, but it sounds like it was just a bunch of surgeons. And this is in JAMA. This is a huge accomplishment. And I love being able to, again, make this more multidisciplinary. How are we bringing people together to do the best treatment for our patients?
And I will tell you, this undertaking of the benign breast disease guidelines has been a several-year process. This was not overnight, but this has taken several years, and there's several different manuscripts.
And the beauty of this is that it was done also with the Society of Breast Imaging. So it wasn't just a bunch of surgeons. It was the Society of Breast Imaging. As a matter of fact, and I wish we would have been able to do it for this particular offering, we've gotten Cap, the pathologist, involved in the next 3. I really wanted them to be involved in this. We weren't able to get that done under the time frame because I've got issues with the pathologist and fibroepithelial.
You could have just put a period after I've got issues.
I've got issues.
You would have all believed it.
And I'm going to tell you what, because I'm old enough to know that when we used to do cores, it was going to be a fibroadenoma or something cancerous or so. It was just very clear cut. And we could do whatever we did with the fibroadenoma. And then I noticed about 15 years ago, this shift. And then everything became a fibroepithelial lesion, and they wouldn't call it anymore. And that drove me crazy. It drives me crazy still today. And I'll talk to them and I'll say, well, what's the deal with this now? I mean, we're not seeing an uptick of these. Why are you calling them differently? Well, unless it meets all the strict criteria for fibroadenoma, we're going to call it a fibroepithelial lesion. And the treatment ramifications of that really change. And that's been a real problem. And it's hard for me, even looking at these recommendations, to still want to continue to excise these fibroepithelial lesions. So I want to hear what you guys say about that, because I'm going to take a little bit different tact on it, but I want to hear what you guys are thinking.
And I thought that was great because they kind of acknowledge practices like yours at the end of the paper, where they kind of say, hey, if you're in a practice where you're seeing all fibroepithelial lesions, you need to kind of sit down with your pathologist and have a discussion and try to figure that out, because you are going to be doing a lot of unnecessary surgery. And what Susan started with, which is great, is when we have people on the operating room table, we want to know 99% of the time that we need to have them there, that this is a clinically indicated procedure. So I have pretty good experience with most things being called fibroadenomas, few things called fibroepithelial lesions, and I forget what the statistic was. I think it was it 70% of fibroepithelial lesions or something along those lines that would end up still being fibroadenoma. So I think that's important when we talk about counseling for our patients, that most of these patients will still be benign fibroadenomas.
So does anyone have pathologists that routinely just say fibroepithelial lesions? So I have patients that get imaging and biopsies in several different locations. And there's this one group of pathologists at this one diagnostic imaging place that they send to that consistently just says fibroepithelial lesion and nothing more. Anyone else have that?
That's kind of been my problem. Now, I got them to say what they favor fibroadenoma, or we'll have to have a discussion about it. But it's maddening still, because now I've got to stop what I'm doing and talk to them if they haven't put that little disclaimer on there.
So Ellie, if you see fibroepithelial lesion favor fibroadenoma, are you okay with that? Or if it's 2 centimeters, are you still leaning toward excision?
You're listening to the Next Breast Thing podcast. We'll return in a moment after this brief message from our sponsors.
What do surgeons want? Not having to wait on nuclear medicine makes our day much more efficient.
With MagTrace, we can start now at 8:30.
It decouples those appointments from radiology and helps with patient experience also.
The efficiency that is afforded has honestly revolutionized my day.
Hologic, redefining breast care from screening to surgery. MagTrace is a registered trademark of Hologic. Julie Margin-Taylor, Crystal Gallagher, and Michael Boland were paid consultants for Endomag. For MagTrace indications, warnings, and precautions, please reference the instructions for use at eifu.endomag.com.
Breast cancer recurrence doesn't wait for symptoms. Signatera is a tumor-informed circulating tumor DNA test that detects molecular residual disease months before imaging. From neoadjuvant response to long-term surveillance, get unparalleled insights to inform next steps. Signatera is backed by Medicare coverage and more than 175 peer-reviewed studies. Learn more at natera.com/Signatera.
And now, back to the Next Breast Thing.
So Ellie, if you see fibroepithelial lesion favor fibroadenoma, are you okay with that? Or if it's 2 centimeters, are you still leaning toward excision, or you're good with it?
I'll say I haven't come into that situation in practice, at least where I'm operating right now. The pathologists have been kind of hammered on this point, and they commit to either a fibroadenoma or a fibroepithelial lesion. And what they tend to do is say on that fibroepithelial lesion, cannot rule out benign phlodes. Then I'm like, okay, great. You just put the phlodes word on the path report. Now the patient's freaking out. So I haven't come into that situation, but I suppose I would talk to the pathologist, talk to the patient, see if they're symptomatic. But if they're saying kind of 2 different things in the report, it would just require discussion. But I do feel, especially as an early person in my practice, I don't like those reports where things are a little ambiguous, and I would probably err on the side of excising it versus watching it, just because that's the part of the career I'm in. I don't have the years of experience to see how this pans out. So I'm usually going for the more definitive option.
And that's why the guidelines help.
No, but devil's advocate time. This drives me crazy. And this is kind of how, maybe I've done this so long that I've just gotten jaded, but okay. So what? It's a benign phylloides. I biopsy, it says fibroepithelial lesion. And unless they're really clear cut, I'm going to tend to watch that. And so what? I watch a benign phylloides grow for 6 months. I don't think I've hurt that
Before
patient.
you go further, for our non-virgin audience members, what is a phylloides?
A phylloides is going to be different. I mean, there are basically 3 divisions of phylloides. It's benign, borderline, and malignant. And they are a little bit more of a single cell line. They do tend to grow. If they're malignant, they can metastasize, and that can be a real problem. So I'm not poo-pooing those guys. But if it's a question of fibroepithelial lesion, the worst case scenario here really is probably not going to be a malignant phylloides. It's going to be a benign phylloides. And so what? It's 6 millimeters bigger in 6 months. Okay,
Well,
then
where did it
size
start? Wait.
Yes,
It
I
started
think
at 5 millimeters and it's 6 millimeters bigger. That's highly significant. 4 centimeters and it's 6 millimeters bigger doesn't matter much.
Yeah, but okay, but so, again, what's the worst case scenario of watching a benign phylloides grow for 6 months?
It takes over the brat.
It's not going to happen. Yeah.
I don't think so. I think what we're touching on too is this is not just an isolated event. We're figuring out, has this been on prior imaging? Has it grown at all? And you're right, it's the rate of growth, not just a number on it. And are there any symptoms associated with it? And I like how the paper kind of put in a threshold of a size. And I think it's also important to provide reassurance for patients where it is concordant with imaging, meaning that, hey, this looks what we think it is. It's been there. It's not bothering them. They don't need to have surgery.
So, Carla, what do you do with the benign phylloides?
That I find on Final Path?
No, on core biopsy.
I'll excise those. I think I've had one patient that had a fibroepithelial lesion. She would come into my clinic. This was years ago on a gurney. She had significant medical issues. I mean, there was a lot going on. And that was a very clear thing to say, you don't need to do that. But otherwise, for the most part, you can take these things out. And I think the guidelines even talk about sort of if you don't excise it, sort of following it for 2 years like we do with a lot of other lesions. And I did follow that patient and it was stable, but I'll excise most of them. And the thing that I kind of started kind of going back to the fibroadenoma is that one of the things for indications for surgical excision is surgeons may consider excision of a biopsy-proven fibroadenoma based on patient preference or symptoms. And I think what we know is that a lot of patients that you're seeing in these scenarios have a palpable mass and want that out. And so while we talk about a lot of these things, most patients are going to want removal, have masses that they can feel. And I think you're hard pressed to say we shouldn't do this. So,
but what is guiding them to want excision? It's fear of cancer frequently, not always.
I think
But if you
sometimes,
operate on pain, you get more pain. Unless you're talking about a very large fibroadenoma, if it's a 1.5 centimeter, 2 centimeter fibroadenoma, and it's a young woman, that's usually not the cause of their breast pain.
Yeah, I think when it's isolated pinpoint pain, sometimes I find this actually with thin athletic women where it's like over rib area, and it can be smaller that you press on it, it hurts on there. I do agree, though, that some of it is don't operate for fear, because then you'll just end up giving people, I call it a polka dotted breast. Because
I call it railroad tracks.
Yeah, there's some people who are one and done, and there's other people who have multiple. If they're not bothering them, they're not growing, just like a lipoma on the body. You don't have to go after every single one.
But I do think it is our job to explain and calm them down about this. Listen, we biopsied it. It is a fibroadenoma. It is completely benign. If it's not really bothering you, the pain that you're having, I don't think is probably attributable to that. Because Susie, if it's near a rib and pressing on a rib and it's small, they're probably not feeling it. Those posterior ones we tend not to feel. We tend to feel the more superficial ones, right? Unless they're very thin and these are large. But that's not the average American.
Are any of you guys offering percutaneous excision with a vacuum assisted device on a kind of small one? No, I mean, yes. I mean, I'll do that frequently on small lesions. We'll just take a vacuum.
No, we work in real
needle.
hospitals, Michael.
I'm sorry, I've got a skill set that you hadn't mastered, or even cryoablation. I mean, we don't have to go to the operating room with all these patients.
Yeah. So, Michael, I did fibroadenomas, and I know that you were in the first breast fellowship, which I have so much trouble saying with a straight face. Michael, for my co-host, Michael believes that he was in the first breast fellowship program in the country.
First approved.
Although I think I finished training before him, so I'm not quite sure how he was the first one. But at any rate, I digress. So cryoablation in the early 2000s, they had a registry. I believe it was called the FACT Registry. Were you involved in that?
I did.
So I participated in that. And women hated cryoablation, which is why it never took off. Because if they want it removed, as we are just discussing, it's because they can feel it. So now we're increasing the size of it. Now you'll tell me that goes away. No, it does not necessarily go away. And it sometimes never goes away. And the reason why you don't know that is because those patients left your practice and went to your competitor and goes, there's a crazy guy down this road
falsehood
did this and I still want it out. And then they removed it. And you thought it was a success. It was not a success.
Okay.
Which is why fibroadenomas.
Broad brushstroke. What about percutaneous?
But we should point out that in the guidelines, so again, if we're talking about this paper, the guidelines do support cryotherapy and vacuum assisted excision. So while that may not be certain people's practice, it is in the guideline.
It is accepted. Correct. Yes. I think that the percutaneous biopsy, what size would you do on that, Michael?
2 centimeters or less, typically.
And it is able to get sucked up because they're hard, right? Fibroadenomas are like little rock.
No, this thing could carve right through them pretty well. It takes a minute because you've got to sort of eat it like a cookie and keep readjusting your transducer, but you could get rid of them.
Cookies really fast, Michael.
Well,
I don't know.
Why is
that analogy?
When do you not recommend surgery? When do you say, I am comfortable watching this, observing this? And if you say that, what's your follow-up? Susie?
Yeah. So is it concordant with the imaging? Has it not changed?
Let me clarify that though, because it can change. So I think that's one of the important things that's on here.
Has there been a substantial rate of growth?
And what does that mean?
Greater than 4 to 6 centimeters. I think most of us agree that's reasonable to go to the operating room for that. And I think what we're talking about is around the 2 centimeter, let's say that.
So we're saying a rate of change of 20%. That's what is in the guidelines, just to be clear, because you're talking about overall kind of numbers, which, most people will do, but they say about a 20% change. I can't remember if it was every 6 months to a year, but I think part of that is just knowing that these things will naturally grow a little bit. So if you have a 2 centimeter and it goes to a 2.3 centimeter mass, we might go, that's something, but that's probably not clinically relevant.
Right. So during your general surgery days, when you were thinking about like an aortic aneurysm, even though someone has an aortic aneurysm doesn't mean they need an operation. But if it's changing substantially, and in this paper, we're talking about greater than 20% over 6 months to a year, that's a pause.
And about 80% will not change in size, really. I think that's the number. They remain stable. So that's important to note and important information to relay to the patient who's very nervous. Every woman who comes in thinks she has cancer, and I totally understand that. So it is our job to calm them down and educate them about this. So, Carla, what's your approach to these women?
It really depends on what they're coming to you with, a palpable mass versus sort of a finding on mammogram. One of the things that we all know is these are very common in younger women. And so one of the things when I talk with residents, mostly, but sometimes the fellows, is you have a 20-year-old who comes to you with a palpable mass. You have a 30-year-old that comes to you with a palpable mass. And you have a 40-year-old that comes to you with a palpable mass. And we're all going to kind of think about the differential a little bit differently. And probably if we get a fibroepithelial lesion or a fibroadenoma, those women are going to come to you with sort of different concerns, right? The 20-year-old might be concerned because she's got a big mass that's kind of shaping her breast, and that's cosmetic part is really important to her. The 30-year-old may feel the same. She might be more worried about cancer. The 40-year-old, both she and I are going to be, even if it's biopsy proven fibroadenoma, I'm not going to be worried, but she may be more concerned about what that means because she's 40 and she's got a palpable mass and she's concerned about that. But I do have some patients that I think want surgery and don't need it. But for the most part, the patients that I see, they've got palpable masses. They're usually 2 centimeters or greater, and we're taking them to the operating room. And to be honest, it's a really fun operation. These patients do great. They pop right out. Their breasts look like they've never, ever had surgery before because the breast tissue just sort of fills in that area. So it's a very satisfying surgery for both patient and surgeon.
So wait, let me put reality on this. The majority of breast surgery in our country is done by who?
General surgeons.
Correct. In my training, like 1,000 years ago, I thought I'd never seen the capsule of a fibroadenoma because it was removed along with a whole area of breast tissue.
Fair.
So to say the breast doesn't look any different, it depends on who's...
It shouldn't. It shouldn't. If you're doing the surgery right.
Correct. But I would venture to say that I cannot sit here and say, oh, overall, this surgery is done correctly, and you dissect down to the capsule and you basically enucleate that. I'm not convinced of that because when we have fellows coming in, that's not always their experience in residency if they're not trained with breast surgical oncologists. So I think we have to be very careful with how we frame this. It's a great surgery in the right hands, but it's not always the right hands. Ellie, your thoughts?
That's a really good point you bring up, Susan, and I didn't necessarily connect those dots. When I was a resident, I did a fibroadenoma removal with a general surgeon, and I remember it took him like 2 hours to take this thing out. And he took a huge capsule around it. The breast looked terrible after. And I remember thinking, and then I did that case, and then I did a case with a fellowship-trained breast surgeon, and she popped it out. It enucleated. It looked so nice. And I remember just being like, I wonder
what's the difference? We are not bashing general surgeons.
I'm just feeling that way.
I want to be sure that it is understood we are not bashing general surgeons in the slightest bit.
No.
There are some people that do a specific surgery better than others. There is a correct way to do this. And the goal is to not remove normal breast tissue along with a fibroadenoma. If we are removing that, that's not necessarily done.
Yeah, 100% agree. If you are any type of surgeon, you need to be knowing your indications, and this is not cancer. There are not margins associated with this, and be mindful. This is being thoughtful.
Well, and I did want to bring up a point too that Carla brought up, thinking about who the patient is, because I did have a patient who was like 70. It looked like a fibroadenoma. And in my mind, I was like, that doesn't really sound right. So ended up taking her to the operating room, and it ended up being a borderline phyllodes.
Wait, you did a core biopsy on...
Yeah, we did.
Initially. Okay.
Yeah. And
I just want to be clear.
Correct. Yes.
Right.
Yes, of course. We did a corneal biopsy. It wasn't really conclusive, but the radiologist looked at it and they're like, oh, yeah, it's a fibroadenoma. It's probably fine. She's 70, whatever. But just didn't really line up.
That's a great point. A 70-year-old is not going to give you a fibroadenoma, so that's not concordant.
Right.
These are the things that we always have to think of. So, Michael, you've been unusually quiet. No more devil's advocate?
Y'all just kind of moved right past. You did. Y'all moved right past.
So let's have your takeaway from this episode.
I'll tell you what was interesting to me in the paper was on the margin issue for a benign phyllodes is that we don't really have to strive for a margin. And I don't know that that's really particularly well known. It wasn't to me. And so we don't really have to try to get a centimeter margin around a benign phyllodes. We could just take that thing out intact, unless we cut right through the half of it or something like that. So there's not a margin aspect to a benign phyllodes we need to get out, which was good information.
And that is definitely something that has changed over the years. A definite guideline that has changed in most of our careers, except Ellie. I mean, that has definitely changed over time. I remember taking women back for larger margins.
Oh, yeah.
And I'm thrilled that I don't have to do that any longer. Carla, your takeaway?
2 things.
Oh, a double.
Yeah, less so on our specific discussion, but just about these guidelines. I did pass this along to my APPs. I think it's a great resource. And the second thing is I consider myself pretty up to date on a lot of breast surgery, and kind of in preparing for this podcast, I read from start to finish and I learned a couple things that I didn't know. The big one that was news to me was with the benign phylloides, sort of considering a genetic counseling or genetic testing after family history. Now, I will say I found it a little vague because it was sort of individual and family history, but I think that I'd like to kind of dive into a little bit more at some point.
I think it's vague because it's evolving.
Yeah, you can tell.
It is one of those things that we're on the cusp of. There's some things out there in the literature, but not necessarily enough to say you need to get it. But if you're operating on a woman and she has a benign phylloides and her mom does also, that's unusual. It causes you to take pause and say, maybe this is the patient we should get testing on. Ellie, your takeaway?
We didn't specifically touch on it in this episode, but in the paper, the part...
Shocking, isn't it?
I know, we went through so much. But the big part that I noticed, at least in different hospital systems, is the mention of truly concordant fibroadenomas that you don't need to do serial imaging afterwards with ultrasounds, especially differences between systems. There's some places where they're going to have you do ultrasounds for 2 years, and there's others where they don't. And I think just kind of mirroring what everyone else has said before, this is a really good paper to read just to share with your radiologist, share with your teams, share with your APPs, because we're doing unnecessary imaging in a lot of places still. And this could cut down on a lot of anxiety and just reassure patients that, hey, if it's concordant, if it's really a fibroadenoma, if it's tiny, we're good. We don't need to do that.
I think that's an incredibly important point. I think that we all lose sight of the fact, imaging fatigue and these 6-month follow-ups. If we're biopsying it and it's a fibroadenoma and it's benign and concordant, why do we need to continue to follow it? Isn't that why we did the biopsy, to prove that it's a fibroadenoma? Great. Now we don't need to follow it. And so I think that's an incredibly important point. Susie, we started with you. We'll let you get the final words.
This is important. These are multidisciplinary people who came together. They're from different institutions across the United States. And Michael, I think it's super exciting that now the pathologists are going to come in on the future. And for those people who don't do breast surgery day in, day out, here's a great resource. And it's out there.
Well, that was a great note to end on. I actually think that we did not get through many of the topics in the manuscript, but we hit the high points and we hit the things that we see most commonly. So, to all of our listeners throughout the entire breast community, we're so excited you've joined us on this journey, and we'll see you next time on the Next Breast Thing podcast.
We look forward to connecting with you on the next episode of The Next Breast Thing, a podcast by the American Society of Breast Surgeons for the breast community.
Also, join the conversation on our Facebook group by searching the Next Breast Thing podcast group on Facebook.
Finally, the content within the Next Breast Thing podcast represents the views, thoughts, and opinions of the co-host and may not necessarily reflect the views, thoughts, and opinions of the American Society of Breast Surgeons.
Until next time, this is Carla,
Ellie,
Michael,
Susie,
and Susan. And always remember, if you're part of the breast community and can't seem to find the answers, this is the Next Breast Thing.